excited to introduce our next speaker, Dr. Sarah Arron. Dr. Arron is a dermatologic surgeon and director of the High-Risk Skin Cancer Program at UCSF. This clinic cares for patients who are at risk for skin cancer due to organ transplant, leukemia, lymphoma, or genetic indels. She specializes in an advanced procedure called Mohs micrographic surgery to treat certain types of skin cancer. Dr. Arron's research interests include studying skin cancer, particularly in patients who are immunosuppressed. She earned a medical degree at Weill Medical College of Cornell University and a doctorate at the Rockefeller University. She completed a residency in dermatology and a fellowship in Mohs micrographic surgery and procedural dermatology at UCSF. Dr. Arron is an associate professor in residency of dermatology at UCSF and the Helen Diller Family Comprehensive Cancer Center. Please welcome Dr. Sarah Arron.
I'm lucky because I get to work with transplant patients in the dermatology program, and by the time most patients come to see me, they are post-transplant and doing really well, and so I'm seeing the happy outcome of what we all know is a very long and challenging road. But my focus is really on the long-term care of transplant recipients and many of the issues that happen after transplantation due to the immunosuppressive drugs that are needed to preserve that allograft. And hopefully someday, I think Dr. Batty will put me out of business. I think that's all of our goals. These are my disclosures. I work with a lot of pharmaceutical companies, almost all of them related to skin disease and none of them related to transplant. So at the University of California in San Francisco, where I'm a dermatologist, we actually have a multidisciplinary program called the High-Risk Skin Cancer Program. And it's focused around both the medical and surgical care of patients who are at high risk for skin cancer. And I'm a skin cancer surgeon myself, so I trained in general dermatology and then did fellowship in surgical dermatology. And so most of the patients I see have already been diagnosed with skin cancer. But transplant recipients have such a high need for skin cancer care that these are the patients I tend to see for long-term follow-up as well. And so these are the facts, and the facts are not terrific. Up to 70% of long-term transplant recipients will develop a skin cancer. And if you take the total population of US transplant recipients, it's about 10% of them at some point are going to have a skin cancer, and the longer you live, the higher your risk. And this can significantly decrease quality of life. Most skin cancers don't kill patients. They just cause a nuisance or need to be treated with topical creams or surgical treatments. But after transplantation, patients can develop many skin cancers and wind up seeing dermatologists every other month or up to every month for surgical procedures to take care of the skin. And so what I really want to focus on is how can we prevent this and how can we mitigate these harms to the patient. We don't often think about skin cancer killing people. We talk about melanoma a lot, but the other skin cancers typically don't. But with immunosuppression on board, your body's less able to fight off that cancer in the same way it's not going to fight off the organ. And so we do have patients dying of skin cancer after transplant, and this is something we would like to prevent with enough early education and prevention. And what causes skin cancer? 99.9% of them are caused by the sun. And sun protection is the best strategy to prevent skin cancer development. Now, it's easy to have this conversation when I'm talking to parents at schools about sunscreen and skin cancer prevention, because if you start at age 4 and wear sunscreen for your whole life, it can really help your skin. Most people who are being listed for transplant have already gotten most of their sun from a history of just doing outdoor activities and living life. So oftentimes there's not much we can do about the sun exposure we've had in the past, but we just try to prevent additional sun exposure moving forward. The earlier we diagnose skin cancer, the easier it is to treat. And that's why dermatologists are so passionate about engaging with our transplant providers and getting to our patients earlier before there's a problem. But now, even at UCSF, where we have a whole program around this, roughly half the patients who come in who have been told about sun protection have already forgotten. So I always say it's kind of like how the dentist has to tell you every time to floss your teeth, and then you floss your teeth for a couple weeks, and then you forget, and then you see them again, and then you floss your teeth for a couple weeks. This is the same with sunscreen. Less than half of transplant recipients routinely use sunscreen, and yet the more you remind someone, maybe the more likely they will be to put it on. So let's talk about why this is important. This is what skin cancer looks like. I'm going to walk through some of the basics. Now, some of these are pretty subtle. These are, these are 4 of my lung transplant patients. You know, pretty subtle. You might not know it's a problem, but if you're growing a lump like this, you're going to bring it to your doctor's attention, hopefully, and get immediate care. The reason being because when I, as a surgeon, am taking care of patients with these really aggressive tumors, it becomes very, very challenging and complicated. And I don't put these up to scare you, except to say I want to see you up here. So I'm going to teach you about what skin cancers look like and what to look out for on your own skin. Now, after transplantation, the risks grow up dramatically. So compared to non-transplant patients, the highest risk is for a cancer called squamous cell carcinoma. Squamous cell carcinoma grows from the outermost waterproof layer of your skin, the epidermis. It's about 65 times increased in transplant recipients compared to non-transplant patients. Basal cell cancer, this is the most common kind of skin cancer. Lots and lots and lots of people get basal cell cancer, transplant or no. And actually, transplant immunosuppression doesn't bump basal cell up as much as squamous. It's about tenfold increase. Melanoma, this is the one we hear about, especially young people. This is what John McCain had, melanoma. Again, it's a slightly lower increase, but still significant. And then finally, Kaposi sarcoma, which we don't see very much nowadays, but actually in our transplant recipients, it's an 84-fold increase. And why is this one so high? It's because KS is caused by a virus. And so if you are immunosuppressed and protecting your kidney, you're also prone to viral infections, and this viral infection happens to cause cancer. So again, some of these are really, really obvious, and these are slides of a basal cell. This is a squamous cell. This is a melanoma. Hopefully, if you saw this on your skin, you'd say something. The challenge is that most skin cancers are not so obvious. So here are very, very subtle cancers in patients. You can kind of see this is very slightly depressed right here. It looks maybe a little bit like a scar, but the patient doesn't remember having had any scarring there, and it's progressing, it's getting bigger. That's a little basal cell carcinoma. This is a early squamous cell carcinoma. It's kind of a red, sun-damaged patch. It's not going away, it's not healing. And then here, this tiny, tiny little dot actually is just a very, very good catch of a melanoma in situ. So again, a very early melanoma before it ran into trouble. And I would never expect anybody to recognize any of these cancers. That's what dermatologists are trained and paid to do. So the trick is come and see us if you don't know what something is on your skin, and let us say, oh, don't worry, it's an age spot, or oh, that looks like a spider bite, or oh, I'm not so sure about that. Let's take a biopsy and see what it is. That's what we're here for. So as I said, some more pictures of basal cell cancer. It's the most common cancer in the United States. Most of them are on the head and neck because they are caused by the sun. So these kind of crusty, shiny, pearly papules. Basal cell cancers almost never spread throughout the body, virtually never. They can, if you ignore them for many, many years, invade deeply and become challenging to remove. But the good news is they really don't impact a person's general health unless they're very, very neglected. Now, basal cell cancers can be treated with a variety of procedures. Most of them are surgical. There are some topical creams to treat very early basal cell cancers. And so I tend to tell patients, just talk with your doctor about what you think is most appropriate for you. Squamous cell cancer is the one that is really a challenge for my transplant patients. It's the second most common in the general population, but after transplantation, that ratio flips, so you start to see more squamous cell cancers and fewer basal cells. And this is what we call transplant hand. Very, very common for older white transplant patients to get lots and lots of these scaly, sun-damaged patches on the backs of their hands, or for men without hair on the scalp. And these are often precancerous little patches that we call actinic keratoses. If they're left alone for a long time, they'll develop into a squamous cell cancer. And if you're heavily immunosuppressed, you don't have to be 75 years old to get this kind of skin cancer. This is a 35-year-old Latina lung transplant recipient with a squamous cell cancer on her lip. So we really want to watch out for our transplant recipients because they're developing these cancers younger, and they're developing these cancers even if they're not your typical white patient who is believed to be at highest risk. Now, melanoma is really the most dangerous of the three. Melanoma is much less common. There are about 60,000 cases in the US every year, but every year this number is going up. And it's not just our ability to detect these cancers, it's also the fact that where our grandparents' generation went to the beach in these long bloomers and kind of full-body bathing suits you can see on Downton Abbey, nowadays, people are going out in the sun with very little cover-up. And so this is all leading to an increase in melanoma mortality. I teach patients when they're looking at new spots on their skin, what we call the ABCDEs of melanoma. This is a dangerous lesion is one that is asymmetrical, one that has a kind of irregular border. It's jagged, it's not round. It might have variations in color. So here you have a kind of darker red. There's a sort of gray-white veil here. It maybe looks a little more black down here. A diameter that's bigger than 6 millimeters or bigger than a pencil eraser. And then most importantly, something that's evolving or changing that you noticed before and now it looks a little different. These are all signs of things that you should bring to your doctor's attention. As it turns out, melanoma in African American patients also tends to come up on the palms and the soles. That's a very high-risk site. So I always tell my Black patients, look at your palms and your soles because that can be a really easy spot to miss if you're checking your skin for new things. And this is a very busy slide, so I'm not going to belabor all of these numbers. This is an example of the kind of research we're doing at UCSF in a group that we call the Transplant Skin Cancer Network. This is a group of investigators from 26 transplant centers around the US, and we've done a retrospective study of transplant recipients with a 5 and 10-year outcome to look and see, first of all, what are the rates of developing skin cancer and what are the rates of dying from skin cancer after transplant. This had never been measured, and it's actually very significant. And so what we did was we partnered dermatologists and transplant providers at these centers to review our patients with data from the transplant registry and then from medical record review. And what we find is that the total rate of skin cancers, almost 1,400 per 100,000 person years. That's a very numbery thing. It doesn't really tell you anything, except that if you compare it to all cancers in the US, it's about 3 times that rate. So just skin cancer in transplant recipients is about 3 times more common than any cancer anywhere for anyone. That's a big deal. And if you look at the patients who are most likely to get those skin cancers, these are the major risk factors. Men have a much higher risk than women. We don't know if that's because of biology or because, ladies, are your husbands likely to put on sunscreen? No, yeah, so maybe it's behavior, maybe it's sun exposure, sunscreen use, maybe it's biology, nobody knows. White patients, significantly higher risk than non-white patients. That being said, we don't have data from this study on the color of a person's skin from fair to dark. We just know what race they report being. But we have other studies that show that it's not just the race, it's the skin color you have and the tendency of your skin to burn in the sun that gives you that risk. So even if you have very dark skin, if you are somebody who finds that your skin kind of gets tight or tingly or reacts to the sun, that can increase your skin cancer risk as well. Patients who have thoracic transplants, so heart and lung, have higher risk than liver and kidney. So this is great news for this room. It's a tough talk to give to the lung transplant recipients because they have really high risk. We think this is because heart and lung transplant recipients have a need for much higher levels of immunosuppression, and so this is a proxy for that. Older patients, the older you are at the time of transplant, the higher your risk. And the more years you're on immunosuppression, so the longer you are out from transplant, the higher your risk. So these things add up as well. We actually looked at the year of transplantation comparing 2003 to 2008 for other reasons. None of these things are relevant to you all unless you were transplanted in one of those 2 years. But fundamentally what we're looking at is that the skin cancer incidence is increasing. We actually think that has to do with the awareness increasing. So we're screening people more, we're diagnosing things more, we're reporting these cancers to the transplant registry more, so we're measuring more of it. And this is our UCSF cohort between about 2004 and 2008. Here's everybody at the time of transplant without any history of skin cancer, and over time, this blue line are the kidney, liver, and pancreas patients. By 20 years post-transplant, about half of them have had at least one skin cancer. So you know, the good news is the longer you live, the better you're doing with the kidney. The bad news is you're going to need to come and see me. And I'll skip that slide. So now that I've given you this doom and gloom, what are we going to do? Well, prevention, really important. Early detection is really important, and then aggressive treatment if a cancer does arise. And the most important part of prevention is avoiding the sun. And in the Bay Area, on a day like today, it's not too difficult. There's a really fun song by Noel Coward that says, "Only mad dogs and Englishmen go out in the midday sun because only people from England are so crazy." Probably because they don't have any sun there. But really what the song is about is avoiding that sun between 10 a.m. and 4 p.m. That's when the UV rays are strongest. It may be that it doesn't seem very sunny, it seems foggy, or you think I'm just going to the supermarket, I'm walking from my car, you know, to the store. The sun is there. If you can see your hand in the daylight, that's UV radiation. So I tell people to look at your own shadow. If your shadow is shorter than you are, then it means the sun is really high in the sky and you should find some shade or put on a hat. You're being exposed to strong UV. Later in the day or early in the morning, you can see as the sun is setting, your shadow gets really long. That's a good time to go out for your walk so that you'll be able to climb the 4 flights of steps that Dr. Huang requires. I don't think I will be eligible. You can actually measure the UV index, and the Environmental Protection Agency has a website and they report the UV index. And so you can see even in San Francisco, California, during the summer, we do reach very high UV levels. This, you know, if you're the kind of Silicon Valley data nerd that likes to look at this kind of thing, you can have, and there are many apps that will send this to you. I think the latest Apple Watch may report it. So you can get an alert that says, whoa, the UV index is high, you should put on sunscreen, which I think is really fun. If you are crafty, you can buy these UV beads on Amazon. Outside of UV light, if you're wearing them indoors, they just look white. But then if you put them in UV light, you take them outdoors, they turn these really pretty colors. And I used to have a nurse that would make a bunch of bracelets for me to give to my patients so that they could actually see, like, oh, it's actually pretty bright out. And I believe it's Blue Lizard Sunscreen recently started making their bottles out of this kind of plastic so that you can see when you're on the beach that you're actually in the UV light. So that's a fun reminder and a cue. But yeah.
Those beads, do they wear out over time?
You know, that's a really good question. I don't know the answer to that. I have some and they still seem to work, so.
Where do you get the beads?
If you look for UV beads on Amazon, I find that's the easiest place to find them, is to search for them on Amazon. So sunscreen, how many people in the room are wearing sunscreen today? Yes. Wait, of those people, how many of them already have their transplant? Yes, okay. And it's a rainy day, right? So sunscreen is incredibly important. And there are so many people on the internet who want to tell you all the dangers of sunscreen because big indoor tanning lobby is actively spending millions of dollars every year to promote the idea of a healthy tan so that people will use their indoor tanning beds. The truth is, UV radiation causes cancer, and the best way to block it is with sunscreen, and there are a million kinds of sunscreen, so whatever your personal concern is, I can help you find one that's right for you. The most important thing, it doesn't matter what brand you use, is that it's got broad spectrum coverage of UVA and UVB. UVA, ultraviolet A, long radiation causes aging, causes skin cancer. UVB causes burning, causes skin cancer. So even if you feel like you're not getting a sunburn, so you're not getting too much sun exposure, you're still getting a lot of UVA. These things also cause freckles, age spots, sunspots, loss of elasticity, wrinkles. So not very good for just general cosmesis. So if that's what it takes to motivate you to put it on, put it on. It actually needs to be applied very liberally. This is a shot glass. It takes a full shot glass of sunscreen to adequately cover the entire body in a bathing suit. That's a lot of sunscreen. It takes a tablespoon to cover the face. Now I tend to do a big dollop like a I don't know, a quarter in my hand and smear it all over. And don't forget the ears and don't forget the back of the neck. If you're using a moisturizer or a makeup with sunscreen in it, it's got to be at least SPF 30, and you have to be putting it in places people don't normally put makeup on, like over here in your ears. I take skin cancers off behind the ear all the time, back of the neck, so you're gonna wanna put it everywhere. And the most important thing is to look for one you'll actually use. There is no magic brand. Expensive is not better. Go into Walgreens or Rite Aid or CVS and open them all up. The worst they can do is throw you out for smelling them. You know, if you're willing to put it on, then you're going to use it. If you're not willing to put it on, then it's just going to sit in your cabinet and that won't help you at all. You can also get sun protective clothing. I used to have to give out catalogs of very specialized companies that would make these sun protective clothing, but now you can find them online all over the place. Even Land's End, LL Bean, they talk about having UPF or ultraviolet protection factor woven into the fabric. And clothing is terrific, especially in this area, because it's cool enough that wearing a long sleeve jacket to the beach is pretty common. I'd say it's harder for my patients who live in the Central Valley where it's really hot to cover up with long sleeves. But some of the fabric is incredibly light, and it's woven much tighter than an average t-shirt or jacket or long sleeve shirt. The UPF of 50 means that about 1 in 50 or 2% of the ultraviolet rays are coming through, and you don't have to reapply that, and it's not sticky. So for some people, it's a better choice than sunscreen. If you compare that to an average white t-shirt, that's a UPF of 7. So that's not really that great. So I really am a fan. For golfers, there are sleeves that you can put on that kind of cover the arms and the back of the hands. And then when you go indoors and you're having your hot dog afterwards, you can take it off and you've got your t-shirt on. There are hats that have UPF built into them. So I'm a huge, huge fan of these. Hats get a grade from me. This is a C. This is a visor. It's not protecting his ears. It's not protecting his scalp. It's protecting kind of the upper part of his forehead. This is a baseball cap. It's only slightly better because it's protecting the top of the scalp, but the ears are still exposed. This is a much better hat. This one gets a B. The challenge with this hat is it's a straw mesh weave, and if I'm holding it up to the light and seeing the light through it, then the UV's coming through it. So really the best kind of hat is the Indiana Jones hat. It's covering the ears, it's covering the scalp, it's got a nice broad brim to cover the face, and so I'm really trying to bring back the hats. And there are lots and lots and lots of styles to choose from. This is much easier to give this talk in Texas where men wear big hats, so I don't know why we can't bring them back up here. So people will ask me all the time, but Dr. Arron, won't I get rickets if I'm as good with sun protection as you say? And the answer is no. First of all, because your nephrologists are not going to let you be vitamin deficient. They're putting all kinds of things into that handful of drugs. But the true answer is that, we get vitamin D from many, many, many sources. Our bodies can make it. Our bodies can make vitamin D in the skin when the sun hits the skin. That is absolutely true. So if you are blocking the sun from getting produced in the skin, yeah, sunscreen is blocking 95% of that vitamin D production. But the other way to get vitamin D is to eat it in leafy greens, healthy vegetables. There's lots and lots of dietary sources of vitamin D. So yes, the pro of vitamin D is bone health and maybe some cancer inhibition, but the con is that you're going to get skin cancer if you don't protect your skin. And dietary sources of vitamin D are some of my favorite things to eat. Salmon, tuna, eggs. I do not personally like cod liver oil, but I don't mind yogurt. And then you can take it as a vitamin with no skin cancer risk at all. So the folks who say, oh, you know, these dermatologists are just being paid by big sunscreen companies to tell you to use sunscreen and become vitamin D deficient, I will say I am not paid by any sunscreen company. And I take vitamin D supplementation, and so far I do not have rickets. So these are my kids. Pictures, I know. Oh, I feel that way too because this picture is about 10 years old. But the idea is that you can still have fun and practice safe sun. So they have their little head-to-toe bathing suits and their sun hats. And please, parents, protect your children. Now, what about early detection? What's going on your skin? People really, really push hard to make sure that transplant patients are seen by dermatologists. And for many years, dermatologists went around the country saying, every patient, every year. That's our mantra. Every patient, every year. I like this, the font when I copied this over somehow made this very big, transplant dermatology clinic recommended. I can only say that because I'm from UCSF where we have a transplant dermatology clinic and they don't have one at Davis and Stanford or CPMC. But the truth of the matter is it's not so much that a transplant dermatologist knows anything different or special than a regular dermatologist. It's just that their radar is up. Their threshold for actively intervening has to be lower. You know, sometimes when you're a really healthy kidney transplant patient, you kind of don't remember to tell your doctor, well, maybe we shouldn't just watch this and see me in 3 months. You know, I have a kidney transplant. Maybe we should do a biopsy. It's worrying me. I tell my patients to look over their own skin, and there's lots of different ways. This is a sort of very creative with the mirror. Having somebody look at your back if you live with someone who's willing to do that for you. Your primary care doctor can also look at your skin and look for anything new, or just make an appointment with a dermatologist, and that's what we're there for. Now, when I meet a transplant patient, the first visit is really all about what's the history. I want to know why they were transplanted, because some of the reasons that we transplant patients also increase cancer risk or risk for other skin conditions. Some of the reasons for transplant are things that have other skin findings, and I've actually been in a situation where I could tell the patient was under immunosuppressed because their sarcoidosis was creeping back up in their skin. And so we want to partner with the transplant team to help out. It's good to know what immunosuppressive medication a patient's on and if they've been on it before transplant. There are some antibiotics and some other drugs that really make the skin sensitive to the sun. And so we want to help prevent that sun sensitivity. And then I like to know the history of sun exposure. Cancer risk goes up with a history of more sun exposure, so where a patient grew up, whether they've had a skin cancer before, whether they've seen a dermatologist before or not. We talk about field treatments. These are topical or light treatments that we use to try and reverse sun damage in the skin. And so if a patient's used those in the past, we can talk about whether we should use them again. And then it's really important to look people over head to toe. So you're going to be getting in a gown for this visit. We look at everything: hair, nails, eyes, the works. And then I will risk stratify a patient. And that just means thinking about what are the risks that you as an individual have compared to other transplant recipients, and how concerned am I that you're going to get cancer in the next year, 2 years, 5 years, ever. And some of the things that we look at are the same for transplant or non-transplant. So we talked about this when I showed you all those numbers. Older white men, that's the classic. Anybody whose skin burns easily, anyone who has blue or green eyes or red or blonde hair. I basically carry all the risks with me around just as a demonstration. The more sun you've had, the higher your risk. And if you've had a skin cancer before, or even before transplant, that means you're almost certainly going to get one again. And so the idea is, if this is not an if, but a when, how closely do we watch you so we catch it early enough that we can take care of it quickly? And then there are some factors which are specific to transplantation. So I think I mentioned these before: older age, longer immunosuppression, and higher levels of immunosuppression. And then there are some drugs which seem to confer a higher risk than others. So cyclosporin and azathioprine, patients who have taken those have a higher skin cancer risk than patients who have never taken those. Tacrolimus and Cellcept or mycophenolate, those seem to be kind of middle of the road. And then sirolimus or everolimus, rapamycin, those seem to be somewhat less bad. You know, people like to say, oh, it's protective against cancer. It's not that you have less risk for cancer than a non-transplant patient. It's just that you have less risk for cancer than a patient on azathioprine. And there are pros and cons to all of these medications, and some are easy to take, and some are difficult to take, and some will be your nephrologist's favorite, and some will be their least favorite. So a dermatologist can't change your immunosuppression. We can only make recommendations based on what we see. So for example, really good evidence that after one skin cancer, if you're able to change from a calcineurin inhibitor to an mTOR inhibitor, your risk for additional cancers will go down. So what do? I call the transplant team and I say, hey, did you know this? And they say, no, because I don't read all the derm journals. And I say, good, yeah, I'll send you the paper and think about it. And sometimes it helps. Warts, kind of interesting. Lots of transplant patients get lots of warts. Warts on the hands, what? I know, right? And warts are caused by virus. And I think they're just a sign that your skin is immunosuppressed. And so maybe the more warts you have, the more skin cancers you have. Nobody really knows. It's not that the warts will ever turn into skin cancer. They don't do that. It just means we need to be looking at you closer. So we talked about every patient every year. The actual truth is we don't really know if screening every patient every year for skin cancer is going to reduce deaths from skin cancer. We have no evidence of that. Yes, of course, if we look at everybody's skin every year, maybe we can catch all the cancers earlier. It certainly gives us the chance to talk to patients about all the things we've been talking about here today, and maybe we can identify specific medication risks or other skin conditions and work with our patients. But there are also downsides to cancer screening. You know, if you're going to go to a dermatologist, somebody's insurance is going to pay for that, so the system bears that cost, and maybe that cost would be better spent on preventing some fungal infection or treating or trying a new medication. You know, if our dollars are fixed, we want to spend them in the place that will get the most bang for the buck, and maybe that's not the skin. If you see a dermatologist and you have a concerning lesion, you're probably going to have a skin biopsy. That makes people really nervous. There are some risks associated with biopsy. You might get a skin infection, or you might have some bleeding afterwards, and that's a potential harm. And then finally, lots of patients aren't well enough to come to yet another doctor visit, or they live really far away from a dermatologist, or there isn't a dermatologist in the area that knows about transplantation, or sadly, some nephrologists don't know that skin cancer is an issue after transplantation, and so they're not sending off their patients. And so there are pros and cons to screening. And so this network of dermatologists who focus on this area really wanted to answer this question. We wanted to say, in a perfect world, if we were going to target screening in the place where we could get the sort of most benefit for the effort, both on the patient's part and the doctor's part and the healthcare system's part, how would we do it? And we do that by what we call risk prediction. So risk prediction basically tells us, based on a patient's own personal factors, what are their chances of getting a cancer? And let's screen them when their chance of getting the cancer is high enough that it makes sense. So for example, if you are a woman over 35, you may get mammography for screening for breast cancer. If you are a person over the age of 50, your doctor may recommend a colonoscopy to screen for colon cancer. But we don't recommend mammography to men over 50 because the risk of breast cancer in men is incredibly low. It's not zero, but it's low. And we don't recommend colonoscopy to people under 30 unless there's some reason to do so. So we want to recommend skin cancer screening in the same way. So the first thing we did was call up a lot of people who know a lot of stuff in this area. We did what we call a Delphi study or a consensus study. We reviewed all of the papers that recommend skin cancer screening after transplantation, and none of them were really evidence-based. They were all opinion-based. And we asked the dermatologists and transplant physicians that were willing to partner with us. We had 84 of them altogether at 42 different transplant centers. Questions about who would you screen and when and why, and what's important to you. It's really hard to get 80 people to agree on anything, but this is a very specific method that's designed to do that. And what we wanted them to tell us is, how do we decide who to screen, who should be doing the screening, and what are our recommendations? So these were the recommendations. Now, this is not to say that anybody's going to do what we say. This is just what we're asking. So the first is, number one, the transplant team should look at a patient and decide, is this patient at risk for skin cancer or not? And this should be done at least by the time of transplant. You could do it at the time of listing. Now, lots of patients will get listed who never go on to transplant, so maybe that's not efficient, but at least by the time a person gets transplanted, look at them and say, what's their risk for skin cancer? The next request was, we need some evidence-based tool. You know, I can't just look and go, you're at risk, you're not so much at risk. What's the calculator? Well, now we didn't have one when we did this study, but I'm going to show you the one we built. They wanted this magical calculator to take less than 5 minutes of their time, and ideally not involving the doctor at all. Too busy, let the staff do it. They actually optimally wanted something that the staff could do without the patient. Just really easy, you know, just go into the medical record, boom, 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 and it's done. Now this is all risk stratification. When it comes to actually screening and looking at a person's skin, the transplant docs and the dermatologists agreed it should be a dermatologist doing that, and that regardless of any calculation that's made or any risk assessment that's made, any patient who's had a skin cancer before should continue to be followed by their dermatologist with whatever recommendation the dermatologist currently has. So nothing we see should change that. They generally felt that patients should be screened within 2 and 5 years, and agreed that the highest risk groups were the white patients, and that as your skin gets somewhat darker, maybe your risk gets a little bit lower. What the team didn't really know is how you combine these risks to screen patients to detect cancer. And the consensus was that we'd want to have a dermatologist look at 50 patients to catch one cancer. So that's like me screening everybody in this room to catch one skin cancer. Everybody thought that that was a reasonable thing to do, and I agree. Because if we're screening only 5 people in this room and they all have skin cancer, we're missing somebody. So we'd rather be broad. So we gave them the tool that they wanted, and this is hot data, not yet been published. We're working on publishing this right now, but this is our score. We call it SCREEN, or the Skin Cancer Risk Evaluation After Transplant. Davis is going to be the second site to do it because UC is doing this now. This is a score that takes in 5 common risk factors for cancer, so being white, having a skin cancer before, being older, being male, and having a heart or lung transplant. And you get some points for each of these, and these points go into a calculator, and they collapse down into 4 risk categories: low risk, medium risk, high risk, immediate risk. And you can calculate your own if you're really motivated to do so. If you look at this highest risk group, this is an immediate risk group. Look how many of these patients are going to get skin cancer. Here it is at, I can't even see the numbers, 40% within 2 years after transplant. That's really high risk. These are patients we want to screen right away. And if you actually look at this black line down here, that's the threshold the panel wanted. That's 1 in 50 patients. If you take the medium risk group, they acquire their skin cancers a little more slowly. This is immediate high, medium risk group a little slowly. And then here's this lowest risk group. They really don't hit that 1 in 50 mark until about 7 years after transplant. So maybe we don't need to see those patients every year. Maybe we can wait. Now, I don't know, Eric, you tell me, this is a little complicated, right? Yeah, maybe.
Yeah, 5 factors.
5 factors. Oh, it's easy enough. Well, we made it easier. We made a tree. And we're actually, we just applied for funding to put these on pocket cards so that every transplant doc can have it in their pocket. You basically just go through these questions. Are you white? Have you had skin cancer? Yes or no? How old are you? And you just follow that tree down into the risk. And then here's our recommendation. So immediate risk, screen them right away within 6 months after transplant. High risk, screen them sometime in the first year. Medium risk, sometime in the first 2 years. And then low risk, sometime in the first 10 years. Just at some point, screen a patient. Now, one of the things you'll notice is that, well, gosh, these low risk patients, maybe they're never going to see a dermatologist. What if they have something percolating along? Should we not send them? This is screening. Screening means looking at someone's skin when they have no complaints. You haven't, the doctor hasn't found anything, the patient hasn't found anything. It's just like mammography. It's just screening. Now, if my patient comes to me and says, I've got this new spot on my arm and I don't know what it is, I don't care if that patient is in the lowest risk category and it's not time yet. They go, right? So lesion-directed referral to dermatology is still really, really important, right? Or if the patient has some infection or something's going on, send them to dermatology. This is for patients who have no problems with their skin at all, that at some point we should look at the skin and see what's going on. So this is exactly what I just said. This is, screening only applies to asymptomatic patients. Refer people right away. Now, there is another caveat to this, and this is something that we're really actively studying now. This tool does not incorporate risk for Kaposi sarcoma or genital dysplasia. Genital dysplasia, what's that? Penile cancer, cervical cancer, vulvar cancer, anal cancer, cancers down below. Those are all viral, and those cancers, you need to be screened by either an obstetrician gynecologist, OB-GYN. Men tend to get screened by dermatology or urology. Now, these cancers aren't included in this data set, so our screening risks don't calculate out the risk for these genital cancers. Turns out these cancers disproportionately affect patients of color. And so patients of color may be much less likely to get a sun-exposed squamous cell carcinoma on the head, but more likely to get a genital cancer. So I tell when I give this talk to doctors, referring doctors, I say, do not forget to refer your patients for genital screening as well. So I don't have a handout for this talk, but there are cards at everybody's seats. We have a website. And there's more information about this on our website. It's at skincancer.ucsf.edu. Here are 2 of my lovely transplant patients who agreed to be poster children on the website. We have on this site, please share it with your friends, we have an information pamphlet which shares a lot of what I've talked about today. You can read it on the site or you can download it. You can download it in English and in Spanish. We also have a research study. We would love to have any or all of you involved if you have had your transplant already. If you haven't, we'll put you on the list and you can call us when you do. We are looking at transplant recipients and when they develop skin cancer and trying to get more personalized information about the genetics as well. So if you're interested in signing up for that study, you'll find the link on our website and the same place. And all of this is done by a really big team, and most importantly, the kids who work in my research lab. I usually drag them with me to sessions like this, but they're all off doing really important medical school interviews, and I want them to go off and be the doctors of the future. So I'm here by myself, and I'm happy to answer any questions. Thank you. This is a great question. Is once a year enough? It really depends on what the dermatologist is treating and how frequently it needs to be treated to keep it under control. So for example, I showed pictures of the transplant hands, with these scaly, red, precancerous sunspots. We call those actinic keratoses. Sometimes my patients come in for a once a year, and I freeze some of these spots. I have this cold liquid nitrogen gun that basically burns them off. Anybody know it? Yeah. Love it. Oh, wow. Most people go, oh, here she comes with the gun. We freeze those spots off to treat them before they take root into cancer. Now, for some patients, I'll do 2 or 3, and I'll see them in a year, and I'll do 2 or 3, and it'll percolate like that forever. And some patients, I'm doing 15 or 20, and I go, maybe you should come back in 6 months. And they come back in 6 months, and I'm doing 15 or 20, and I go, maybe you should come back in 3 months, just to keep things under control. If a patient's had a skin cancer, so squamous cell carcinoma or basal cell carcinoma, generally in dermatology, we recommend twice a year skin checks, at least for the first few years after that cancer, to make sure nothing new is coming up. Most dermatologists feel bad about dragging patients in. If you ask to be seen more frequently, your doctor should have a good reason why yes or no. So I think it's a useful thing to discuss if you're being treated. Yeah.
I was going to ask a similar question. My husband had a transplant. We go twice.
Twice a year is pretty standard. I would say more often really depends on, at the end of that dermatology visit, saying, when should we come back? The patients that I tend to see more than twice a year are patients who've had multiple skin cancers, patients where I'm freezing things or treating things at every visit, patients who have a lot of new growths coming up very, very rapidly. And then we're starting to do all kinds of things which I wouldn't even talk to a pre-transplant group about, because you'll take yourselves off the list and go down to the dialysis center and say this looks good. But twice a year is fairly standard unless there's a significant acceleration of skin disease. That is a terrific question. So the question was, if you haven't had your transplant yet and you haven't had a skin cancer before, but you know you've had a lot of sun exposure, does that build into our algorithm? The answer is no. And the reason is that our algorithm is based on the data that we have from actual people. And none of that data actually involves surveys of people, right? So when we go back and we say, in 2003, there were 15,000 transplant recipients in our database, we don't know what they look like, we don't know who they are, we don't know where they lived, but we do know that they're white or black or old or young. Smaller studies, and these are mostly in renal transplant patients either in England or in Australia. There have been a few small studies where they actually looked at cancer risk and they surveyed patients and they said, did you grow up in a hot climate? Did you have a lot of sun exposure? All of those things did increase risk. So if I'm seeing a patient and they have lower risk factors, but they're telling me they worked outdoors their whole life, I'm going to sort of mentally adjust that and make it more precision. That's one of the things we want to study now, is how can we include actual patient information along with this big registry information. The other thing I sometimes do, or the transplant team sometimes asks me to do, is see patients when they're being listed to do a tune-up. So I say, well, you've never seen a dermatologist before, but I'm going to look at your skin, and if there's extensive signs of sun damage, we're going to talk about whether we need to treat that and kind of get you in the loop ahead of time so that when the transplant does come, you're all ready for it. I think if a person's had any kind of skin problems before transplant, it's worth the transplant team getting the opinion of a dermatologist, because it may not be something the transplant service can gauge. Is this going to be an issue or a non-issue? Obviously, as a skin cancer surgeon, I would like everyone to see a dermatologist all the time, regardless of transplant. So I'm very pro-derm. But if there's no issues on the skin, then there's no need to be seen before transplant. This is the first group I've spoken to that didn't ask me about specific brands of sunscreen, so I'm really excited. It is all over the place. It's all over the place for 2 reasons. Well, I'm going to say it's all over the place for 3 reasons. The first reason is that until pretty recently, transplant recipients weren't living long enough to get skin cancer, right? The biggest problems were rejection. And the idea of having a kidney transplant recipient who's 30 years out, well, we didn't start doing kidney transplants till when, the 60s? So you didn't have that many, right? So this is a really late post-transplant complication. And so for the field of dermatology to recognize it took some time. When I was doing my training, which was about 10 years ago, this was like a hot new field, transplant dermatology. And so all of these people in big academic centers were getting really excited. And so now if you go to a big dermatology meeting, there's all these sort of UCSF, UC Davis, Stanford doctors talking about skin cancer after transplant. That information hasn't entirely trickled down to every community practicing primary dermatologist in the world. Most of those patients, or most of those doctors will have 1 or 2 transplant patients, and they're really not thinking about it because they're thinking about everything else that's going on in dermatology and in the skin. And so opinions will be different. That's the first reason. The second reason is we have very, very little evidence to tell us what to do, right? So I showed you the best evidence we have. We don't have lots of studies that show us that if you see a dermatologist every year, you'll be less likely to die of skin cancer, or be less, you'll be more likely to get one because you can only get diagnosed with one if somebody sees you and looks at your skin. So that's the other reason, is some doctors say, well, until I see that there's really good data to tell me what to do, you're probably good to be seen whenever. Other doctors are more aggressive and they say, I want to be as, I want to watch you as closely as I possibly can. And then the third thing, which speaks specifically to you, is that you're East Asian, I'm going to guess. Chinese, yeah. So really very little known about Asian patients and skin cancer risk. There's a very well-known Japanese transplant surgeon at UCSF who said to me, Sarah, you're never going to see a study about skin cancer after transplantation coming out of Asia because they don't have it. And that's not really true. Asian patients do get skin cancer after transplantation. It's just the risk is lower than white patients. So if you're a dermatologist and you're saying, oh yeah, I don't know, kidney transplant, it's a lower risk transplant, and you're Asian, and you're a young woman, and yeah, I'm guessing, right? That's what many doctors are doing. I tend to err more towards being really aggressive because I want to catch people before there's a big problem than after.
So 2 more quick questions. I know how much to apply, how often?
I will tell you what I do, which is put it on in the morning before I go to work. And then during the day, I have a brush. And if I'm going out for a walk at lunchtime, I have a brush with like a mineral sunscreen. I put it all over my face before I go out. What the books will tell you is reapply every 2 hours, which to me seems excessive, just tedious. But I do really recommend reapply if you get out of a swimming pool and you towel off, reapply. If you are playing golf and you're physically out in the sun, reapply at holes 6 and 12. My husband says reapply at the turn, but I said that's not enough. It depends how fast you play. If you're a really scratch golfer and you can do a course in under 3 hours, you can reapply once. But if you're like 4.5 hours like me, you have to reapply twice. If you are just going about your daily activities, and I can get you to put it on first thing in the morning every single day, that's a win for me.
Sorry, I misunderstood. I was thinking like Bare Minerals makes those.
Oh, okay. So then there's what kind of sunscreen you put on, right? See, I knew we were going to talk sunscreen. So most sunscreens come as a cream, and you rub in the cream, and the idea is you need to get good coverage. And if you want to know what good sunscreen coverage looks like, I really highly recommend this YouTube video. It's called How the Sun Sees You. If you look it up, it's really fun. Good coverage sunscreen, whether it's a chemical sunscreen or a mineral-based sunscreen, a cream, both will work equally effectively. People don't like to put on sunscreen, so there are other formulations. So one is the powder sunscreen. Right? If you think about a powder, you either, Bare Minerals is one brand, you swirl the brush in the beads, very pretty, you put them on your face, or I have one, it's by Color Science, I carry it in my bag, it's a powder and I brush it on the face. Powder's not very complete coverage, right? I mean, imagine sprinkling some baby powder on your kitchen counter, you're not covering up that whole area. And so it's not going to protect your whole area. So I don't recommend it as a base coat. I recommend it as a touch-up. The same is true for sprays. There's nothing to me more ironic than seeing somebody at the pool who clearly like sprayed themselves and they've got this like streak of white amidst a big sunburn. Sprays don't give you good coverage unless you really wet the skin and soak the skin, and then they feel really sticky. So what's the point of having a spray? So it's not a good base coat. It's a good touch-up. Waxy sticks, I think, are really good, especially for athletes. People who complain about sunscreen running into their eyes, the wax sticks are much more adherent. But if you break out and you have acne, a waxy stick is not for you. If you have sensitive skin, the mineral sunscreens, they are often found in the baby aisle. Those cause fewer breakouts. But if you're like me, I always use a chemical sunscreen. I cannot stand mineral sunscreens. They feel thicker, they feel heavier, they kind of make me look a little white and ghosty, and I'm kind of ghosty enough. So I always use chemical sunscreens. That's just my preference. But there's a different one for everybody. More sunscreens than you can imagine. So just find one you like.
I got a question. Sunscreen and moisturizers, that counts, right?
So it counts. Used to be that most moisturizers with sunscreen were SPF 15, which is not very much. It needs to really be at least 30. Nowadays they're coming more with 30s and 50s, which is good. A pea-sized amount of moisturizer on your cheeks, though, isn't really protecting your skin from the sun. So you have to think about, am I putting on this moisturizer with sunscreen like a sunscreen, or am I putting it on like a moisturizer? Because if you're not moisturizing the back of your neck, then that's where I'm going to be operating. So does the SPF number matter? So SPF, pretty controversial these days because, again, this indoor tanning lobby would have you believe that SPF is a number that means nothing. SPF is a very specific measure of UVB protection, and the higher the number, the more UVB is blocked by that sunscreen. So if you have a 30 to a 45, the 45 is stronger. People will say that beyond about 45 or 50, additional sunscreen, like 70, 100, doesn't matter. The reason people say that is that it's a kind of exponential curve, right? So if 50 is blocking about 98% of the UVB rays, and then 70 is blocking about 99% of the UVB rays, it's blocking more, but it's just incrementally more. The challenge is that that's assuming the sunscreen is used correctly, which means a whole shot glass of sunscreen, which is a lot of sunscreen. And most people aren't using it that way. So I figure as long as we are all agreeing to underuse sunscreen, we may as well use the highest SPF that's available in the brand we like. So I tend to use one that's 70 because it comes as 45 and 50 and 70, and it costs the same for all three, so why not? There's no downside to it. Well, thank you so much.